A prostate cancer diagnosis about 3 years ago shocked an otherwise healthy Stephen Pyenson.
I had planned on having the operation to take it out if I was diagnosed.
In the era of PSA screening, we know that about 60% of men don't actually need to be treated for prostate cancer.
Those men, including Stephen, have a localized low-risk form of the disease. Initial surgery or radiation therapy may produce side effects, including incontinence and impotence, which can affect long-term outcomes and a patient's quality of life.
I actually thought that if I had surgery, my quality of life could get worse.
So Stephen talked with his family and physicians and is following a plan of active surveillance.
Active surveillance is a recently developed strategy of close monitoring. They aren't treated initially, so they get serial blood tests with a PSA, physical exams, and biopsies. If it looks like the disease is behaving more aggressively, they're taken to treatment at that point.
Dr. Julia Hayes from the Dana-Farber Cancer Institute in Boston and co-authors created a computerized model of 100,000 hypothetical 65-year-old men newly diagnosed as having localized low-risk prostate cancer. They either receive treatment or a strategy of active surveillance.
Men who pursued active surveillance had a better quality of life overall, on average, than men who were treated initially.
The study appears this week in JAMA, Journal of the American Medical Association.
Even if we made active surveillance associated with worse prostate cancer-specific outcomes, the quality of life advantage to active surveillance was maintained.
I consider myself very lucky that I have this option to wait it out.
What this study provides is a starting off point for an important discussion between physicians and patients.
Catherine Dolf, the JAMA Report.